Welcome to Clinical Conversations. Back in November, a paper in the Proceedings of the National Academy of Sciences caught a lot of attention when it announced an unexpected long-term rise in the mortality rate of middle-aged whites. A lot of commentary followed, but what remains unknown is the cause or causes of this unexpected increase as measured over the past 15 years. The Commonwealth Fund has just published an issue brief on this phenomenon, which it entitled Mortality Trends Among Working-Age Whites, The Untold Story. We're fortunate to have the authors of that brief as our guests. David Squires and Dr. David Blumenthal are respectively the senior researcher and the president of the Commonwealth Fund. Welcome to Clinical Conversations. Mr. Squires.
Thank you for having us.
Mr. Squires, could you outline briefly the apparent causes of the increased mortality?
Sure. So the original paper by Case and Deaton attributed the rise to a startling and dramatic increase in poisonings, mostly drug overdoses, and suicides.
Yeah.
When we looked at the mortality data, we kind of noticed that the gap between where you would expect mortality rates to be, assuming a decline over the last 15 years versus where they are, was actually it was a larger gap than was explained by those suicides and overdoses. And so we dug into looking at other causes of death and realized that there had been an across-the-board stagnation in efforts to reduce mortality. So, for example, heart disease, where there have been dramatic reductions in mortality for most of the last half-century, deaths leveled off over the past 15 years for this population. And that leveling off and improvement in heart disease had about as large of an effect on the overall trend for middle-aged whites as did the rise in drug overdoses. Oh. And so this seemed to suggest that the story was broader than just suicides and overdoses, which is an incredibly important phenomenon, but it also spans across the board for pretty much all leading causes of death for this population.
You analyzed the same data as Case and Deaton, is that right, or did you use a different set of data for your analysis?
No, it was the same data source. We were fortunate to have an extra year's worth of data, and so our we went from 1999 to 2014. Mm-hmm. We looked up until 2013, and we also looked back further. So our analysis went all the way back to 1968 to get a broader sense of the historical trends, and see just how unusual this phenomenon was.
So Dr. Blumenthal, it sure looks like drug overdoses and liver disease from alcohol abuse account for much of the effect, but not for all of it. So what's the thinking? And as the original authors, Case and Deaton, point or ask, why hasn't anyone noticed this before?
Well, why people haven't noticed it, I can't say. It's one of many things in the progress of science and epidemiology that sometimes emerges when someone looks at data a different way. Mm-hmm. The implications are that something is going on in our society, including in the healthcare system, but probably exceeding that, going beyond the healthcare system, which is specifically affecting a particular part of our population and with considerable detrimental effect. And it raises all kinds of questions which can't be answered from secondary data sources.
Yeah.
And I expect and hope will occasion further investigation about causes.
It was especially problematic among people with lower educational levels, people with high school or education or less. And it was especially true in a belt of states, roughly in the south, from Oklahoma all the way over to, I think, Mississippi and up into Tennessee, Kentucky. Many of these states had not expanded eligibility for Medicaid, but that extension would not have taken effect over, it would have just had an effect, if any, over the past couple of years.
You correctly point out that the Affordable Care Act can't, from a temporal standpoint, really have any role in what we've observed. The question of uninsurance and whether loss of insurance or lack of insurance has a role, I think, is again unanswered. There's no question that the states in which this gap is highest also tend to have the highest rates of uninsurance in the United States. They tend to have the least generous Medicaid programs, and they tend to have less in the way of social supports in general for populations, not just in healthcare, but in other areas. Whether that's an important causal factor, I think remains to be seen. We do know that insurance is a public health promoter. There's ample evidence from authoritative sources that having insurance saves lives, and lacking insurance reduces health in populations. So it would be a reasonable hypothesis to expect that during this period, lack of insurance was playing a role. But it's not easy to relate it to the selective finding among whites, unless whites disproportionately lost insurance during this period.
I wanted to ask you, what worries you most about the trend that you've been studying?
What worries me most is that we are not progressing the way we could as a society in improving our welfare, the welfare of our population, and that there seems to be a set of forces at work among a subset of our citizens that is reducing their quality and length of life. And it doesn't have to be that way. Indeed, it wasn't that way up until roughly 2000, and now something has changed. My guess is that it's not only a healthcare issue, that it's an economic and social and educational issue. And I can't point to a cause, and therefore can't point to a solution, but it is worrisome. There are many, theories that you could point to. You could point to the growth of inequality in our society. You could point to the globalization of the economy with loss of income and wages as a result of foreign competition for labor. You can point to the movement of manufacturing overseas, and maybe that's more disproportionately affected whites who were more likely than African Americans and Hispanics to have been employed and therefore to have lost their employment and also their insurance with that employment. These are all theories you could pursue.
Yeah.
One thing I do not think is, and I think the literature makes this clear and the data make this clear, this is not a failure of biomedical research or biomedicine. The capability to continue to extend life persists, as is evident across Europe and most other industrialized countries where mortality rates have continued to decline at roughly 2% a year. And that's also true in much of the rest of the United States.
Would you say, though, that there is a role for the widespread use of pain relievers, of opioids, which you can't excuse the biomedicine or the biomedical establishment from? There's certainly a role there.
Yeah, I was speaking more of the capabilities of medicine rather than the day-to-day frontline use of medication.
Yeah.
So,
I understand. Probably the most difficult question of all is the question of it's the clinical implications of this. I mean, somebody going into taking call next week and knowing about this increase in mortality among middle-aged whites, what should they be thinking? What should they be more suspicious of, say, prescribing opioids? Should they be more prone to counseling people on alcohol abuse? What would you recommend?
well, the proper use of drugs has always been an important characteristic practice. There is a suggestion that the profession has gotten less careful in response, perhaps, to the pressure to manage pain more generously, and maybe that is playing a role. And there's certainly a societal pressures now on clinicians to be much more careful in prescribing opioids. Alcohol is a long-standing problem. Everyone trained in medicine who's had extensive patient contact has had a huge experience with alcohol and its use, and it has been everywhere. It may be somewhat more prominent now, but it's part of the daily work of medicine to inquire about alcohol and to try to manage it. It's an extremely difficult problem. Our surveys on other topics at the Commonwealth Fund have shown that primary care physicians are not all that confident of their ability to handle behavioral health and substance abuse problems. So I think there's an issue of training and support, which is very important for the training of professionals and for the medical educational establishment to come to grips with. Training in the management of addiction and behavioral health issues of all types really needs to be improved in our nation's teaching hospitals and medical schools. There's one other thing that is difficult for individual clinicians to manage, but is increasingly important for them to be aware of, and that is that health is not strictly a biological factor, a biological outcome, but it is determined often by social and economic factors. And while clinicians typically see these as beyond their control, they need to be cognizant of the incredibly important role that things like loss of employment, marital discord, poor education, poverty, malnutrition, lack of education, that all these things play in the health of their patients and in limiting what they can do to make their patients better. And they need to, as a profession, think about how they can affect those determinants of their patients' health.
That's good advice, Dr. Blumenthal, and I hope the profession as a whole takes it, and I hope that there will be more studies coming from you and the Commonwealth Fund on this topic. I look forward to seeing your findings in the future. I want to thank you both for this interesting chat, and I want to thank you for your ongoing work at the Commonwealth Fund.
Thank you. You're very welcome, and thanks for giving us a chance to talk about our work.
Thanks.
I've put a link to the Commonwealth Fund issue brief on the website, but you could navigate to it quite easily by going to www.commonwealthfund, all one word, .org, and you'll see it right there on the front page. That was the 194th Clinical Conversation. We come to you through the NEJM group. And speaking of which, in the interest of full disclosure, I should disclose that Dr. Blumenthal is a member of the editorial board of the New England Journal of Medicine. My executive producer is Kristen Kelly. You can find this and previous episodes at podcasts.jwatch.org. Thank you very much for listening.